Approximately 75% of physician practices are composed of fewer than 8 physicians. For the majority of these small physician practices, including mine, burdensome regulations can take valuable time away from patient care. We believe that this is particularly true with regard to the Recovery Audit Contractor, or the RAC program, and the ICD-10 implementation. Now, as you pointed out, the RAC program employs contractors to analyze and audit physicians' reimbursement claims for billing errors. The pilot program, which began in 2005 and will begin nationwide this year, has been extremely burdensome on the affected physicians and does nothing to educate them about common billing mistakes. Instead, the program embraces the bounty hunter technique that provides the RACs with incentives to deny claims. While we strongly oppose the RAC program, we believe there are things that CMS can do prior to the national rollout that would improve it. Specifically, CMS should consult with the AMA on the RAC physician communications. In addition, they should make RAC monthly financial reports public and maintain an accessible list of commonly audited procedures. CMS, in addition, should preclude RACs from reviewing claims for the past 12 months. The failure to do so will result in RACs reviewing claims still under review by the carriers and other fiscal intermediaries. RACs should not be permitted to review billing issues arising from evaluation and management services or medical necessity determinations, as they are extremely individualized and extensively clinical review is necessary. CMS should limit the number of records requested from individual physicians. I know of one urologist from California who had a request for 50 of his patients' charts. CMS should also raise the minimum claim level from $10 to at least $25. Finally, CMS should encourage the pursuit of underpayments, as you spoke about, as well as the overpayments, by requiring RACs to accept case files from providers for underpayment reviews, and including as an underpayment those situations where a physician mistakenly neglects to report a delivered service. The AMA also concerns itself about the rollout of the ICD-10, the 10th version of the International Classification of Diseases used in outpatient and inpatient settings. While the AMA recognizes the importance of updating the current coding system, ICD-9, we believe that due to the complexity and the cost of this extensive transition, a plan and timeline must be developed prior to a national rollout. Any transition must take into account the fact that physicians are already struggling to implement the HIPAA electronic transaction standard and also the transition to the National Provider Identifier Number. Given the costs and complexities involved with the move to ICD-10, the AMA suggests that the HIPAA electronic standards be upgraded to version 5010 prior to the national rollout, as the current standard, 4010, is totally incompatible with the ICD-10. In addition, the ICD-10 coding system should be pilot studied and tested so that problems with it can be identified and resolved in advance of a national rollout. Physicians, their staffs, their coders, and other national stakeholders will need adequate education and training very early in the transition process. Due to the significant resources, administrative complexities, and advanced planning required to retool and replace our systems and processes which currently depend upon ICD-9 logic, HHS should work collaboratively with the healthcare industry stakeholders to develop a realistic transition process and timeline. The AMA looks forward to work closely with the Small Business Committee to ensure that physician practices, especially the smaller practices like my own, are able to manage the RAC audit process and prepare for the ICD-9 rollout and transition without compromising health care to our patients.